Hello, my name's Donna Mayer. I'm the Executive Director of the Cholangiocarcinoma Foundation. We'd like to welcome you today. We're very pleased to have Dr. David Loren here with us to discuss photodynamic therapy. Dr. Loren is the Associate Director of Endoscopy and the Co-Director of Pancreaticobiliary Section at the Thomas Jefferson University Hospital. He has extensive experience treating patients with cholangiocarcinoma, and he cares for one of the largest cohorts of patients with cholangiocarcinoma in the United States. He's lectured nationally and internationally on the topic of emerging research and treatment options for patients affected by bile duct cancer. We will have time at the end of his presentation for questions. We ask if you have a specific question that you enter it in the question box to the right of your screen, and then I will be asking it on your behalf. Dr. Loren will not be able to answer any personal questions during today's presentation, so please be sure that your questions are general in nature. We're grateful for Dr. Loren to give his time and expertise, and now I turn the floor over to him.
Thank you, Donna. Welcome, everybody. I'm excited to be here today to talk to you about a very exciting emerging therapy for cholangiocarcinoma, photodynamic therapy, and importantly discuss the OPUS trial, a ray of light in cholangiocarcinoma. This is a trial of photodynamic therapy for the treatment of cholangiocarcinoma or bile duct cancer. I thought it would be appropriate to start with just a review and a discussion of the bile duct anatomy so that we're all speaking the same language. The bile ducts are located in the liver. One of the many jobs of the liver is to make the fluid called bile. And in most medical illustrations, you'll see this as green tubes that come out of the liver and then travel down to the small intestine. When we eat food, we swallow our food, it comes to the stomach and then to the small intestine, where it mixes with the bile, along with pancreas juice, in order to help us digest our food. When the bile is not necessary to be used to digest food, it can be stored in the gallbladder, located here underneath the liver. And the cancers that we'll talk about today are cancers arising from the bile ducts. You'll notice that the bile ducts branch here, and this is an area called the biliary hilum, and this is where the branches into right and left sides of the liver go. And these branches will continue into many, many small branches that run all throughout the liver. Bile duct cancer can affect any part of the bile ducts. So bile duct cancer, also known as cholangiocarcinoma, is a disease that appears to be on the rise. There are about 3,000 cases in the United States annually, so this is not a very common cancer. But in recent years, we've seen more and more of this cancer. And in fact, when we look at mortality data, meaning what are the cancers from which people are dying, we're seeing a rise in this such that this, along with liver cancer, is going to be one of the top 3 or 5 causes of cancer death in the United States in the years to come. Unfortunately, at this time, only a third of cases of patients, when they are diagnosed with their cancer, are resectable at the time of their diagnosis. Even when surgery or resection is performed, recurrence is common and happens in up to 3/4 of cases. For some individuals who have limited extent of their disease that's up inside the liver, liver transplantation may be an option for them to replace the entire liver with a new one. Understanding cholangiocarcinoma means to understand that all of these cancers are not the same. We have an anatomic classification of the diseases so that that depends upon where they are and where they arise in the liver and in the bile ducts. They can be intrahepatic or inside the liver, and this accounts for only a small portion, 10% of cholangiocarcinomas. And because they come in from inside the liver, these patients typically don't have jaundice, but their cancers are found on imaging studies like CAT scans or MRIs. Perihilar or hilar cancer at the branching of the ducts, and I'll show that more to you on the next slide, accounts for the majority of cancers, whereas extrahepatic, outside the liver, distal cancers that are further down the bile ducts account for just under a third of those cancers. And each of these is a unique disease that has different staging and treatment options and prognosis. So from the schematic standpoint, the intrahepatic ones live up here inside the liver. They can occur anywhere inside the liver. There are distal cholangiocarcinoma, which are the next most common. We said 25%. And these live outside the liver, downstream in the ducts. That's what the distal refers to as downstream in these ducts, outside the liver. But the most common ones, and the ones that we'll be talking about today, are these perihilar ones. These are cancers that start from these bile ducts up right where the branching occurs in and around this location, called perihilar cancers, right where this biliary hilum is, where the branching occurs. The approach to a patient who is diagnosed with cholangiocarcinoma means not only thinking about the disease, but treating the individual. So the first questions a physician will ask themselves from looking at the scans are, can the tumor be removed? How big is it? Where is it located? How many are there? Is it one, or are there multiple? Are they located in one segment of the liver, or are multiple areas of the liver affected? Are there blood vessels in the area that are affected? And we take all of this into account in considering who can have a surgery for cure and who cannot. Then we think about, can a patient survive an operation? Are their lungs and heart able to handle an operation, which is a big operation? How is their nutrition status? Unfortunately, because of blockage of the bile ducts, patients often have a compromised nutritional status. Are there issues of portal hypertension or high blood pressures related to blockages that in the blood vessels that occur because of these tumors, or that cause the liver to be damaged, causing the blood pressures to be high, that makes surgery more risky? And is the liver working adequately to help somebody get through a major operation? This last question we ask also by thinking about, once we remove a segment of the liver, how much liver will be left behind, with the question, is there enough hepatic reserve, enough liver function that will be left behind after the surgery to support the individual? And this is both a consideration of the amount of liver, or the volume of liver that's left behind, as well as the integrity, or how healthy is that liver. There are certain diseases that can predispose to cholangiocarcinoma, to bile duct cancers, that may be affecting the remaining liver, that make it a segment of liver that's not healthy enough to support a person post-operatively or after surgery. And in those situations, when the tumor can't be removed, what are the other treatment options? Is a liver transplant or replacing the liver an option? Or if not, what are the other treatments that can be offered to help a person have a high quality of life? When we start looking or learning about perihilar cholangiocarcinomas, these tumors that arise right where the ducts come together, and this is a schematic of what the tumor would look like, we start learning about something called ERCP. ERCP are words, and there are a bunch of letters that stand for words that refer to taking a tube or a catheter or a tube going up in the ducts and putting X-ray material in the duct called X-ray contrast. And they go up into the duct and they let us take X-rays so we can see the ducts. And you can see the bile ducts in this individual here. And I can tell you that these bile ducts are too big because it has been blocked off by this tumor. So if we bring these two together and bring the tumor over to where those branch out, you could understand how the bile ducts get blocked off by the tumor. So that's called a stricture. And here it is again, the same image, stricture. So these are images from an ERCP procedure, and we're going to talk more about the ERCP procedure that is performed routinely in patients with cholangiocarcinoma. So as we think about specifically these perihilar cholangiocarcinomas, the cholangiocarcinomas that arise from the branching of the ducts, we start to think about what are our treatment options. And for patients who undergo surgery, and the idea behind surgery is to cure people, to make all the cancer go away and be removed, what we see is that our long-term survival rate is not very good, and in expert hands, our long-term survival rate can reach, say, 30–35%. Unfortunately, this is a big operation, and operative mortality, people not surviving the operation, can reach up to 15% of individuals, and that's a high number for a surgery. But these are high-risk procedures done for high-risk diseases. There are many patients who, even at the time of surgery, find out that their tumor can't be resected or removed, and that may be due to blood vessels being involved. This is a common cause, or the tumor having climbed up further into the liver, into the second-order bile ducts, further up into the liver, so that the entirety of the tumor cannot be removed, along with the liver that's in that region. These tumors tend to spread to the lymph nodes nearby, and if those lymph nodes are affected, then a surgery will not cure an individual, so they won't undergo this type of resection. And then finally, if at the time of surgery it's determined that the remaining liver that will be left behind is really too small, despite all the imaging and what's been done ahead of time, sometimes surgeries are aborted. In the liver transplant options, for those who can go through a rigorous liver transplant program, the 5-year survival is actually pretty reasonable, 65%, but a quarter of patients don't make it through that process. So what do we do when a curative surgery is not an option for an individual? We ask ourselves the first question, which is there any way to take this patient and take the tumor and shrink it down, called downstaging, to the point where surgery is possible? Most commonly, this is done with multimodal treatments, multiple different types of treatments to treat different parts of the tumor, usually chemotherapy, and in our center, accompanied by photodynamic therapy. Radiation may or may not be a part of it, depending upon the individual tumor. And when downstaging is not possible, we think about shifting the goals of care and have a different mindset and help a person feel as well as possible for as long as possible. And when we spend a lot of time, and should, focusing on helping somebody feel as well as possible for as long as possible, and in doing so, we've known for a long time now that the primary treatment, the primary way to achieve that, is to unblock these blocked up bile ducts and restore bile flow, allowing the bile to do its job once again. In a normal bile duct, we said the bile helps absorb, and particularly helps absorb fats and cholesterol. And in an obstructed bile duct, when those fats are not being absorbed well, we have what's called fat malabsorption, which leads to diarrhea, and chronic diarrhea, malnutrition, and weight loss. Moreover, there are vitamins called fat-soluble vitamins that are important for body function. And when the body function is compromised because of this, patients have a series of difficulties with bleeding, their immune function is depressed, they may have difficulty with their eyesight or nerve problems, and can often have problems with bone pain and fractures, all of which will decrease the quality of life for anybody affected by this long-standing bile duct obstruction. But the most severe complications of long-term bile duct blockage or bile duct obstruction happen in the liver itself. In a normal bile duct with good bile flow, this promotes healthy liver function. However, in the obstructed bile duct, when the bile backs up, it causes jaundice, yellowing of the eyes and skin, darkening of the urine, and lightening of the stool. And jaundice in its own right results in decreased appetite and weight loss, further compounding malnutrition. It can cause itching, which can be severe and intractable, and these further compound and decrease the quality of life that a person has. It can lead to liver failure and infection. And in fact, the main causes of death from cholangiocarcinoma are liver failure and infection in the bile ducts, known as cholangitis. And anything we can do to decrease that, help people survive longer and feel better. So if our primary treatment is to unblock the bile ducts and restore the flow of bile, how do we do that? What are the ways we can achieve that? Well, intraductal ablation, so doing a tumor kill inside the ducts by taking, in this case, in the case of photodynamic therapy, a laser and putting it up into the bile ducts to kill tumor. This restores the continuity of the bile ducts and improves flow. Stents are routinely used, and stents are tubes, and these are tubes that are routinely used to open up bile passages and open up the bile ducts. We can put them on both sides, and often do in the case of these hilar cholangiocarcinomas, and these push tumor aside. They don't actually kill tumor, they push them aside and keep the tumors open. When we consider multimodal therapy, we add chemotherapy because that attacks the cancer cells from the outside. And all of these together can help shrink a tumor and can help keep the bile ducts open for as long as we can. And when I explain our approach to my patients, I tell them to think of this like an apple, where we're trying to both core out the apple from the inside by doing our intraductal ablation and stenting, and then we attack the outside of it by using chemotherapy. So what are the beneficial effects of unblocking these bile ducts? How does it help? Well, we know that we can decrease infection rate, minimizing cholangitis, that infection in the bile ducts. We improve bile flow, which leads to improved jaundice. With the lower level of jaundice allows for chemotherapy to be given, because chemotherapy cannot be given in patients whose bilirubin is too high or have jaundice. Bilirubin is what's in the blood causing jaundice, and when that level is too high, it precludes giving chemotherapy. So by getting good drainage, we can facilitate people getting chemotherapy, which also helps extend life. We know that when the bile ducts are open, the quality of life, which is most important, is improved, and patients live longer when good drainage is achieved. So let's shift and talk about photodynamic therapy. And I'll point out what we've added to this image here is this black tube, which is the scope. And this is the scope that we use to do the ERCP test, where we take our catheters or our lasers and we go up into the ducts, where I showed you we inject that contrast material up in the bile ducts to help treat the tumor. And just as from an image, I'll show you, this is the laser fiber here that you can see we're getting ready for a treatment that we use, and this is the laser that illuminates the tumor. And we'll go into this now about how this works. Photodynamic therapy is a two-step treatment. It involves both giving a medicine and using a laser. In the first step, we give a medicine called a photosensitizer. This is a medicine that's given intravenously, so it's given through the vein, and what it does is it travels throughout the bloodstream. The medication that we use in the United States is called photofrin, or porphyrin or sodium, and that travels through the bloodstream after it's administered. And it's administered in a short infusion, and over the next few days after that infusion, it travels throughout the bloodstream. And in doing so, the cancer cells have a progressive retention of the medication so that it's in very high concentrations in the cancer cells. 2 days after the infusion is given, the laser light is illuminated at the site of the tumor. So we have the ERCP test where we take the laser fiber and we put it up into the bile duct and bring it up to where the tumor is, and we treat the tumor. And we have very specific ways about how we go about treating different parts of the tumor. And we use it. This is called the ERCP that we've been speaking about before with PDT, photodynamic therapy, PDT, up to do the tumor ablation and kill this aspect of the tumor to open up the bile ducts. So how does this work? How does this laser up in the bile ducts kill cancer? So the cancer cells, we said, have a very, very high concentration of the medication. And when the laser is shown on the tumor, it generates an unstable oxygen molecule, and this is called singlet oxygen, an unstable oxygen molecule that is toxic to cells, and this is generated inside the cancer cell. So because the levels of the photosensitizer medication are so high in those cancer cells, it's the cancer cells that are preferentially treated and therefore killed by the medication accompanied by the laser. Now, one very important patient consideration and the dominant side effect of this treatment is something called photosensitivity. And I stress this to my patients very significantly, particularly this time of year that we're coming into this beautiful spring and summer. The photosensitizing medication that we give is given through the vein. Okay, the porphyrin sodium or photoprin is given through the vein, and that travels throughout the whole body, and some of that gets deposited in the skin. Certainly at lower levels than what's deposited in the tumor, but some of it does get into the skin, making the individual very, very sensitive to light. And that sensitivity can last even up to 90 days, although usually it's somewhere around closer to 60. And what we tell our patients is that they should avoid direct sunlight, and this is very important, particularly early on, and even bright indoor light. I had one patient who, at an Eagles game, a night football game, got a sunburn because of the lights from the stadium. We ask that patients wear protective clothing, and SPF clothing is now available online, and we encourage our patients to use that. Wearing wide-brimmed hats, dark sunglasses that are wraparound sunglasses that help protect the eyes. And even makeup will help protect against this photosensitivity on the face. Over time, individuals will progressively expose their body to the light in order to metabolize the medicine or get the medication, burn it out of the skin. So slowly, we'll say take a couple of minutes in the sun, and then 3 minutes in the sun, and then 5 minutes in the sun, and do what's called photobleaching, or basically burn the medication out, metabolize it by exposing yourself to the sun, and eventually that photosensitivity goes away. Now, why is this such a good treatment for cholangiocarcinoma? Why should we be using this or consider using this for cholangiocarcinoma? And why do we now have open a trial, a randomized trial, the OPUS trial, to treat patients who have bile duct obstruction and bile duct cancers? Well, we've already discussed that liver failure and infection in the bile ducts, cholangitis, are the major complications that happen in this cancer and are what determines how long a patient lives. The photodynamic therapy is a locally directed therapy to the tumor, and it has a depth of tumor destruction that opens the bile ducts and gets very close to normal bile duct diameter. I'll show you some ERCP images a little bit later. It's treatment that we typically give once every 3 months, so it's not burdensome in that treatment. And perhaps most important is that the tumors will often involve multiple bile ducts, not just those two big ducts that are branching, but some of the smaller ones that come off right in the vicinity. And the laser light will actually travel up the bile and will treat those areas of cancers that are next to those big ducts and maintain those bile ducts open to allow the bile ducts to flow, thereby prolonging life and improving quality of life. Well, how do we know this? We do have some data. The purpose of our trial is to get more data and to find out in a really well-done trial, is this a good treatment for patients? But we do have data. And the first thing we do is we look and say, okay, in patients who've been treated, let's look back. It's called retrospective studies or retrospective data. We say we've had patients who've been treated. Let's see what we did. Let's see how well they fared. So in a retrospective study that looked back at 184 patients, these are patients out of Europe, of whom 60 had surgery, 68 had stents with photodynamic therapy, and 56 stents were treated with stents alone. Let's try and look and see how they did to get an idea of what we can do to help patients better. Well, of the 60 patients who had surgery, 8% died within 30 days. So this is a pretty low operative mortality rate for these surgeries. So that's pretty good outcomes as far as from surgery goes. But unfortunately, and not surprising, only 22% of those who had surgery, or 1 in 5, actually became long-term survivors. So let's see what happened to the other individuals. So in the patients who had the photodynamic therapy with stents, which will be in the first column here, we see that they were able to get a better decrement in their bilirubin to close to 4, and at 4 is where the jaundice goes away. So the bilirubin went down more in the individuals who had photodynamic therapy compared to stents alone because drainage was better. And then after 3 months, we see that more people, 75% of those in the photodynamic therapy group, were able to maintain their low bilirubin or their good bile duct drainage compared to a smaller number of only 40% in the stent alone group. And the most important statistic is that in the photodynamic therapy group there was an improvement in quality of life, whereas in the stents there was a significant decrease. And in all of the photodynamic therapy literature, that in the studies that have been well done, and there aren't many of them, but in all of them, the quality of life scores have improved. Now, when we looked at survival, when they looked at survival in these individuals and saw that survival, in fact, whether you had surgery or photodynamic therapy, there was no difference in the overall survival of those groups when taking everyone into account. But when comparing photodynamic therapy to stents alone, the survival was better with the photodynamic therapy group. So instead of looking back, we say, okay, we've got an idea now of how patients may benefit from this treatment. Let's do a study, and this was a study that was done in Europe at 2 patients that ran at 2 centers that randomized 39 patients either to photodynamic therapy with stents or to stents alone. And in this study, it was found that patients who received the photodynamic therapy lived over a year longer. So these are the survival curves. Patients live longer who receive photodynamic therapy compared to those who didn't. And in fact, this study was stopped early because the organizers of the study and the researchers felt it was not ethical to withhold photodynamic therapy from these individuals. And another study looking at people who receive stents with photodynamic therapy as opposed to stents with chemotherapy. This is not a randomized study, but it compared people who got stents with photodynamic therapy alone compared to stents with chemotherapy. The 1-year survival for those with the stents with photodynamic therapy was 75%, as opposed to only 12% of those who received stents and chemotherapy. So the survival of stents with photodynamic therapy, not as good as surgery, but certainly much better than stent with chemotherapy. And the overall survival advantage was a year, over a year. And this has been replicated in another prospective study where the benefit appears to be about a year. Mind you, none of these data have come out of the United States. These have all been European trials. And at present, the FDA does not approve photofrin for the United States, for the treatment of cholangiocarcinoma, which leads us to where we are now, asking the question in a very rigorous, well-designed manner in the OPUS trial. The OPUS trial is an open-label trial, meaning patients know and the investigators know what treatment is given. It's an open-label trial happening with multiple centers, randomized. Patients are randomized to receive photodynamic therapy or not. And it's a study of photodynamic therapy for unresectable perihilar cholangiocarcinoma. What is the primary objective of this trial? It's to assess whether photodynamic therapy given with standard of care chemotherapy, and in the United States, standard of care for cholangiocarcinoma is chemotherapy. And so this study assesses whether the addition of photodynamic therapy to standard of care chemotherapy has a survival advantage compared to chemotherapy alone. All patients have stents, and you can see these stents, these blue tubes or straws here, that are up in the bile ducts, keeping them open. All patients have stents in the bile ducts. And so in this study, there are two study groups: those who receive chemotherapy, the current standard of care, or chemotherapy accompanied by photodynamic therapy, which is the study group. The outcomes, the main outcome is survival, how long patients survive with these treatments, with secondary outcomes being how long it takes for bilirubin to come down, what happens with the tumor, does it shrink, and if so, how much and over what time frame, how long does it take for that shrinkage to occur. We assess patients. How are they functioning at home? What is their performance status? And what is their quality of life with these different treatments? Who's eligible? This is a study for unresectable perihilar cholangiocarcinoma. So the cancer depicted in these pictures in blue has to extend to a point where it's non-operable, so up high enough in this cases in the liver so that operations are not possible, either on the right or the left, or might even involve both sides of the liver. Patients who, for one reason or another, can't have the surgery because it extends up into the bile ducts, lymph nodes may be affected, local blood vessels may be affected, such that safe surgery for cure cannot be achieved. Patients cannot have metastasis. The tumor cannot have spread to other sites, and have to have a biopsy that shows that this is in fact cholangiocarcinoma. And for some individuals, this is a difficult thing to achieve because making a diagnosis of bile duct cancer or cholangiocarcinoma can be challenging. There are three study periods, three different phases of the study. The first is the biliary decompression, opening the bile ducts phase. And during this time frame, the goal is to get the bilirubin down to a level where chemotherapy can be given. Patients are randomized during this time frame either to stent therapy alone, where stents are aggressively placed to try to get the bilirubin down, or stent therapy accompanied by photodynamic therapy. Patients continue on to the chemotherapy phase and the treatment phase. All patients receive chemotherapy, but those that have been randomized to the photodynamic therapy phase get chemotherapy along with photodynamic therapy as opposed to chemotherapy alone. And the final phase is the follow-up period. So in this first biliary decompression period, patients get randomized or they get selected randomly either to the standard of care chemotherapy or standard of care accompanied by the photodynamic therapy. And it's during this time that we do the ERCP procedures with stent placement or stents with PDT, photodynamic therapy. Again, the way it's done is a medication is given 2 days before the ERCP test, and then the ERCP procedure is performed, stents are removed, the laser is advanced up and used to treat the tumor, and then stents are replaced up into the bile duct. In some cases, if it's felt that optimal PDT was not delivered at that time, a repeat procedure may be given within the subsequent few days. During the chemotherapy phase, chemotherapy is given according to the standard way that oncologists give these types of chemotherapy for cholangiocarcinoma, with interval ERCP procedures for stent exchanges because the stents will get blocked up and we need to change those out to prevent infections and blockage. And at these ERCP procedures, patients either have the stents removed or the stents removed, photodynamic therapy performed, and everybody has stents replaced. Finally, over the subsequent months, there's the follow-up period. During this time, treatment is given according to the needs of the individuals. ERCP may be performed as needed, and patients are tracked for their performance status, how well they're living their lives, how well they feel with quality of life scores, and we follow the blood test to make sure that the bilirubins and to see how patients are doing with regard to their blood tests. There are some other features of the study that are looked at to try to look at how the body is responding to treatment and to gain further insight to help people in the future. In summary, photodynamic therapy is an emerging treatment for cholangiocarcinoma, but is currently not FDA approved for this disease. This trial is a pivotal and very important trial in making progress for affected patients. And it's only through the dedications primarily of patients and their families, their physicians working with innovative industry partners, can we together try to reach a cure for cholangiocarcinoma. I want to share my last few slides of patients that I've had the pleasure of knowing and treating and showing some of the outcomes that can be achieved with photodynamic therapy. So this is an ERCP procedure, and ERCP images, and these are the initial images. You can see some of the dark lines up here. These are those dilated bile ducts from a tumor that's living right here. And in fact, you can see a little wire that comes up here. But this tumor is taking up this entire space, and all of these bile ducts throughout the liver are big and dilated, blockage of the liver and jaundice. And this patient was told by their cancer doctors he was too jaundiced, he could not receive any type of therapy, there was nothing that he can do. This image is from 2 years later, and this is the same individual, and you can see the ducts have come down to essentially a normal size, and we've been able to reconstitute the bile ducts such that bile flow continues and occurs. And his tumor with photodynamic therapy alone, in this case no chemotherapy, shrank and had dominant control over this time frame. And I'll share with you one other experience. There's been one study published that looks at how to downstage patients. Remember, we said we should always ask, can we get to surgery? And can we take a tumor that is inoperable and make it operable? And there's been one study of 7 patients who had locally advanced cholangiocarcinoma. All of these patients with photodynamic therapy were able to be downstaged and achieve complete remission, complete resection. For all of the patients, no viable tumor was seen close to the inside of the bile ducts where the treatment was given. And after following these patients for almost 2 years, 83% were disease-free at 1 year. 2 patients died, one 9 months postoperatively and one 6 months postoperatively in their follow-up time frame. And this pathologic report is from one of my patients who went from an unresectable tumor to having a T1, which is a small tumor that was able to be completely resected, no invasion of the blood vessels, he had had no spread to the lymph nodes, and the margins of his tumor were uninvolved by invasive cancer. And in fact, it was 20 millimeters or 2 centimeters to the bile duct, to the closest margin. So we were able to achieve a very good surgical response for this individual. This is not the common case, but we have to try to think along these lines to make strides in order to improve the care for these individuals. I'd like to thank you for your time and hope that you too will see photodynamic therapy as a ray of light in the treatment of cholangiocarcinoma, and we advocate for enrollment in the OPUS trial, which is opening sites all over the country. Thank you for watching.
Thank you, Dr. Loren. Did you have a study coordinator from the Thomas Jefferson University that you wanted to also introduce to take any questions?
I do have my study coordinator who should be joining me in just a moment, and we're happy to take any questions either about the study or specifics or anything related to this treatment. Her name is Cindy Miller, and she is a seasoned coordinator who is running the trial here at Jefferson. She's in fact in charge of all of our research endeavors here at Thomas Jefferson, and we'd be happy to take any questions that anyone has.
Okay, great. Thank you. And I'll remind viewers that you can go ahead and type your question into the question box, and then I will ask on your behalf. The first question we have is, what causes the perihilar to be the most common of the three types of cholangiocarcinoma?
So that is a terrific question, and the answer is we don't really know. Some of it has to do with the way the cancers are diagnosed. We know from autopsy studies and from liver explant studies, meaning when we take a liver out of a patient receiving a transplant, that we will sometimes find cancers that are in the liver itself, higher up. And because the perihilar ones are the ones that cause jaundice, they're the ones that are easier to see and that may be detected more often. But what we don't understand is what is the biology of the tumor that causes those to arise in that more specific location.
Okay, thank you very much. The next question is, in the realm of cholangiocarcinoma, what do you consider long-term survival?
As you've seen, the studies measure survival in days. All of these studies talk about 100 days, 300 days, 400 days survival. Long-term survivors are defined as people surviving 5 years because those are people that we feel have cure. Most of the time that the cancers come back, they come back within the first year. And so patients having surgery will often have their tumors come back relatively early in the course. The 5-year survival data is the long-term survival data, but unfortunately, the average survival for a patient who is treated with chemotherapy is in the 9 to 11 month time frame, and so these are difficult cancers for patients.
Okay, the next question is, when you combine the phototherapy with chemotherapy, are there other side effects other than the light sensitivity?
So we haven't seen any problems with mixing those. We do coordinate the treatments so that when we do the photodynamic therapy, because there's always an infectious risk with the treatment, that we try to do those procedures during a period of time where patients' blood counts are not low from the chemotherapy. So we're thoughtful about that. But as far as medication interactions go, there are not interactions between the medications and the chemotherapy.
Okay, great, thank you. The next question that I have is actually a two-pronged question. Why is this treatment not approved by the FDA, and are there other diseases that it is approved for use in the United States?
So, an excellent question. Why is it not approved by the FDA is because there have not been enough data accumulated in this disease to convince the FDA that this should be an approved indication. And the goal of the OPUS trial is to try to get to that point where the FDA will approve it. And there are many, many patients, and most patients, in fact, who can't get the treatment. It's an expensive therapy, and until it's approved by the FDA, it's difficult. Coverage from insurers is very, very difficult. As far as the second part of the question, which is what are the other diseases that photodynamic therapy is used for, the FDA does approve it for the use in lung cancer that's blocking up the lung passages, and for esophagus problems where people have precancerous and cancerous problems in the esophagus that can be treated with this therapy.
Okay, that's the last question that I have, other than, and I will take this one actually myself, is where can I get more information about this? And so I want to let everyone know that today's presentation was recorded, and both the PowerPoint presentation and the recording will be loaded on this Cholangiocarcinoma Foundation website. We will be posting links to it on the discussion board and our social media sites as well. And then also you can get information about it on our website under the clinical trials now enrolling. It's the very first study at the top. And there's a way that you open that window up, and it lists all the different centers that are participating, and it has information for Dr. Loren and also the colleagues that he works with. So if you had any questions, additional questions that weren't answered today, we ask that you post them on the CCF discussion board, and then we'll work with Dr. Loren to make sure that you receive a response. So on behalf of the Cholangiocarcinoma Foundation, I'd like to thank you, Dr. Loren. We appreciate the presentation that you shared today, and we also want to thank all of those who participated. The webinar will be ending now.
Thank you, Donna.